Oh, thank you very much, Leah. And I want to say thank you for inviting me to present today to all of you. And I was telling Leah, and I want to anticipate that this morning I started to have some technical problems with my computer and the internet. So I hope that everything will go smoothly. And I would like to introduce myself. I am Gloria Castro. I have been working for many years at the Department of Psychiatry at UCSF, basically in two programs, at the Infant Parent Program, who was directed by Judy Perkowski, and when I was there as an intern, and then later on by Khadija Johnston. And then at some point, like 7 years ago, Dr. Alicia Lieberman asked me if I would like to join her program because they were working with pregnant women, and what Alicia wanted to do is if we could work together and develop the model of perinatal child-parent psychotherapy to be able to disseminate this and also to train in a way other people who will be able to work with what we call now perinatal child-parent psychotherapy. I had the fortune to work with Dr. Lieberman, and we published in 2020 a book that it's called Make Room for the Baby. And this book is the product of all the years that Alicia's group and my group at the Infant Parent Program, we work with pregnant women, not only as an outpatient, in outpatient clinics at San Francisco General Hospital, but also to be able to provide therapeutic support at the Infant Parent Program, as well as in the Child Trauma Research Program. And today I am going to be talking a little bit about the idea of how we as mental health providers, we are going to be able to help the new parents, to make room for the baby that they are expecting, okay? I would like to ask you that I am going to leave a couple of minutes after this presentation to talk a little bit about your questions or your thoughts. But at the same time, you will see that the model of perinatal child-parent psychotherapy is a relational model. And I would like all of you to have the experience that when I am going to be presenting the material, please do not wait until the end. I want this to be more interactive, and feel free to stop me and to bring up your thoughts, your questions, your ideas about the content of what I am presenting, okay? And as Leah was saying, the reason why I would like to invite you to have your screen on is because this is a relational-based model, and the only way I have right now to see how you are taking in the information that I am providing is if I see your face. But I totally understand that if you are doing something else and it's very difficult for you to turn on your screen, that is okay, okay? But I really invite you to participate in this presentation. So now I am going to share with you my screen. Can you see my screen? Okay, yes. Good. Okay, so now we are going to start. So the presentation is called Making Room for Baby During the Prenatal and the Postnatal Period. And I would like to start this presentation talking about a little bit the language that we are using. And I know that it's very, very important to use an inclusive language when we are providing this information. But I also want to anticipate to you that we are going to use terms like the pregnant person, but when we are going to be talking about some of the clinical aspects of the work, I will not be able to use an inclusive language. And the reason is because all the research that has been done with mothers who got pregnant, okay? Or the fathers of these babies who are going to be very present in the life of these babies. And they also, there is a lot, some type of research that we had the opportunity to review when we wrote the book, in which the research was focused on fathers who were on the process of becoming a father during the perinatal period. But other than that, I want to acknowledge that it's very, very important to think about the inclusive language, and at the same time, probably to advocate for the field in psychology to start doing more research about the wide range of patients or clients that we are going to encounter, okay, in our clinical practice. So we wrote this statement, so it's going to be important for all of us to keep in mind. Okay. So now, this, we are going to, the objectives for this particular presentation is going to be that at least you are going to identify 2 defenses in infants and 2 defenses in pregnant people. You are going to support clients to prepare for labor and delivery, and you will be able to describe what is the imaginary baby, the symbolic baby, and the real baby, and explain the role of repairing relationships between mother and infant. And this is the second, the second part of a previous presentation that we had a couple of weeks ago, in which we talk about the introduction to perinatal child-parent psychotherapy. So I hope that this will be useful to all of you. So first of all, I would like to see if we can define what is the perinatal period. And the definition that I am using is the definition that is used by the medical providers and some of the mental health providers, that the perinatal period, perinatal means around, you know, and the perinatal period is the time frame that begins in conception through the first year after giving birth. Something that is very important is that I would like to invite you to think that really the life of a baby does not start during the physical conception, but is going to start even when the mother begins to have the psychological conception about becoming a mother and having a baby. And that psychological conception is not going to coincide with a physical conception, just for us to keep that in our mind, okay? And I always like to remember this statement made by Donald Winnicott, who was a pediatrician, and also he was a psychoanalyst. And I really like what he used to say, that he said, the story of a human being does not start at 5 years old or at 2 or at 6 months, but starts at birth. And he added something that I really like. And he said, even before birth, if we like, okay? So I really like this statement because it reinforces my idea of the way we have been working and the way the field of perinatal mental health has been coming up here in the United States and in other countries in the world. So what are the lenses that we use in the perinatal and in the postnatal period? And the lenses that we use is, first of all, and I want to highlight this, is a relational-based model, okay? And also, we take into consideration that this baby and the family in which the baby is embedded is embedded in a cultural context. And we, as mental health providers, we need to take into consideration the cultural aspect of this particular family. And also, another thing that is important is that when we are working with the perinatal and postnatal period, we are providing a lot of support and some particular clinical interventions, not only to the baby and to the parents or the family of this baby, but we are going to have the opportunity to provide a particular consultation, I would say, to the different levels in which the baby and the family are embedded. And in this particular case, we are going to focus on the medical system, okay? And also the work that we do has a developmental approach. It's not only about the development of the baby, but also when we are working with these pregnant women or women during the postnatal phase, we really need to pay a lot of attention to the developmental stage of the parents of this baby, as well as the developmental stage in which the baby is going to receive the services. And this is also not only a relational or developmental approach, but is very trauma-based focus approach, in which we are going to gather a lot of information about the difficult experiences that these parents have had in their lives. And specifically, we are going to be trying to explore the childhood difficult experiences of the parents. So here, one of the things that I would like to share with you is that we can get these families because we get referrals during pregnancy. The ideal would be to be able to get the pregnant woman or the pregnant person during the first trimester of pregnancy, okay? But sometimes, the majority of the times, what we are doing is that we are getting the clients during the second trimester, and that is okay. And then we will be able to continue working with them during the third trimester, helping them to be able to welcome the baby. And we are going to provide therapeutic support around labor and delivery. And sometimes, if the baby has been born with a medical situation that requires the baby to be in the Neonatal Intensive Care Unit, we are going to be working with the family in the NICU until and then the baby is going to be discharged from the hospital, and we will continue working with these babies and their families until the baby is 1 year old. And yesterday, I was making a similar presentation. Actually, it was a learning collaborative with a group of people from the University of Oregon, and they had a very good question. They told me, Gloria, how come in the book you indicate, you and your the other authors like Dr. Alicia Lieberman, Manuela Diaz, and Griselda Oliver, you are talking about that perinatal CPP works until the baby is 6 months of age. And I responded to them, you are right. The reason why we are extending the support until the baby is 1 year old is because we are working with a lot of women who are dealing with some mental health issues like depression, anxiety, PTSD, or even postpartum depression. So if one of the things that happen with the mental state of the mom is that if we do not work with them during the pregnancy, what is going to happen is that when the babies are born, they are going to be more, for example, a baby who was his or her mom were pregnant, and during the pregnancy, the mother had very high levels of anxiety. What happens is that the level of cortisol is going to increase, and that level of cortisol is going to pass directly toward the, through the placenta to the baby. And these are going to be babies that are going to be what we sometimes call a fussy baby, or they are going to be very difficult to be soothed. So that's why and another thing that we know based on the research is that these babies whose mothers struggle with postpartum depression or depression during pregnancy or anxiety, these babies are going to have, that is going to have an impact on two domains of development. One of them is expressive language that is going to be delayed, and the other one is the gross motor development. And so if we say that the cutoff for perinatal CPP is 6 months, unfortunately, we are going to miss the next 6 months. That is when the baby becomes more mobile. And that's why we have extended the services until the baby is a year old. Now, one of the things that I would like us to do right now is to think about these particular questions. Why do you think that it is important to focus on the perinatal period? What could be your concerns if the pregnant person with a history of trauma could not receive therapeutic support? And how could you frame perinatal mental health to your client or to other providers? So I am going to stop sharing my screen, and I am going to invite all of you to think about these questions. What do you think? Why do you think that is important, the perinatal period?
Can you repeat the questions one more time?
Oh, yes, and we can put them in here if you want.
Oh, yeah, in the chat.
Oh, do you have them in the chat? Or not yet?
Not yet.
Okay, let me share my screen. So these are the questions. So why do you think that it's important to focus on the perinatal period?
I think for pregnant mothers, self-care is really important to ensure that they're taking care of themselves with either proper nutrition, proper rest, not too much physical activity so that their baby can develop. And if they're stressed out about other things or concerned about other things, they might not consider themselves a priority, especially if they have more than one child. And what affects them affects the baby.
Yeah. So, Sonny, I really like what you are saying, because in a way, when the mother takes care of herself, she's taking care of her baby. So that is very good. Thank you very much. What other ideas about why it's important to provide services during this period of time?
I think it's really important to educate the parents about all the changes that the body and mind is going to go through to help prepare them and establish a support system.
Very good. And Dalila, what you are saying that we need to do is to anticipate to the pregnant person what are the changes that she's going to experience at the level of her body as well as the level of her mind. Okay. And because if we anticipate that, they are going to be prepared for labor and delivery. So that is
a little better prepared, yeah.
yeah, because we really don't know until the baby is born, until we go through labor and delivery. but at least, as you were saying, they are going to be a little better prepared than if we do not talk about these kind of things. Okay. So
the prenatal period is also the start of the relationship with the baby, the anticipating who this baby will be, the perhaps reliving all the things that the parent either wants to repeat or doesn't want to repeat with their own child, and all the attributions, positive and negative, that they may have about this growing being in their belly.
exactly, Karen. And you are talking about something that is important. Most of the times, the referrals that we get from the medical providers is because they notice that the mother is not connecting to the baby during pregnancy, and they are very concerned. They don't even talk about the baby, let alone talking to the baby. So to be able during the prenatal period, specifically during pregnancy, to help the mother to bond with the baby is going to allow us, is going to allow the mother and the baby to develop a secure attachment. So that is very important. And then, why do you think that these interventions will be very good for the mothers who have a significant history of trauma? Why the perinatal period is important if they have had a significant history of trauma?
I can share.
Yes,
I think that trauma impacts our body and our mind in certain ways that can negatively impact, have a negative impact on our mind, and also like on our bodies from the stress of trauma, and that is going to be passed down to the baby. And as you were talking about the cortisol, right, and that being high, and understanding that trauma impacts development, and so both the development perhaps of the parent, and also certainly the development of the child. So yes. Thank you.
Thank you, Alejandra. You are completely right, because what perinatal child-parent psychotherapy is trying to do is to avoid the transmission of trauma from one generation to another one. So all of you cover very important things. First of all, how we can support the mom to take care of herself, and in that way, she's taking care of the development and the growth of the baby. The other thing is the relational base, that the relationship between the mother and the fetus during pregnancy, and how we can support these parents to be able to bond with the baby even before the baby is born. And then I think that was very important, as well as we are trying to prevent the transmission of trauma from one generation to another one. Very good. So let's continue. So the result of the conversation that we were having is that, of course, these interventions begin in pregnancy and are going to continue after the baby is born, is going to promote maternal and infant health and well-being, and the maternal and child health outcomes can be improved. These babies are going to be born at the due date that they were supposed to be born. We are not going to have so many preemies. And the other thing is that we are trying to enhance the maternal reflective functioning or the paternal reflective functioning, okay? And this, of course, is going to promote secure attachment. Something that is very important for us to talk about is that perinatal CPP is going to be working with the unconscious processes and representations that are going to be expressed in the here and now during the parent, when we are working with the parents, okay? This model has, the theoretical approach is very psychodynamic, and it's going to support loving and benevolent memories and contains some of the malign and hating affective repetitions. In a way, it's going to be able not only to contain, but to avoid, to repeat some of the patterns of interactions that the parents had before getting pregnant, that are related. The patterns of interaction that they learned, these parents are coming from the way they experience some of the traumatic situations in their lives, okay? And the therapist or the provider may become an angel in the present, in the present moment. And this is very important. The way we are going to relate to the parent is going to be very important, because we are going to make them feel safe. We are not going to judge them. We are going to listen to them in a very empathic way. Completely different from what happened when they were, experienced trauma. One of you was talking about how important it is to prepare the pregnant person about the changes, the physical and psychological changes that they are going to encounter during this perinatal period. And I think that is important, because what we are doing is giving back the control to the parent, the control that was taken away when she endured a lot of trauma. So during this time, we are going to create a therapeutic space, okay? And this therapeutic space is going to allow the parent to be able to reflect, to construct a narrative of their experience of pregnancy and how they are making the transition from pregnancy to parenthood. Also, this space is going to be is going to allow the parents to speak about the unspeakable, things that they have never talked about. We are going to encourage them to talk about those things, because that is the only way in which they are not going to reenact that particular situation with their babies. And also, this is the therapeutic space is a space in which they are going to become aware of the process of becoming a mother or a father. And the most important thing is going to be a space in which they are going to be welcoming their baby. The pillars of therapeutic attitude, they are very, very important, because this is the way we are going to be working with them, okay? And for example, we have here that we notice the feelings that the parent is experiencing in the here and now. And in order to do that, we really need to be attuned to the present emotional experience that the parents are having, and how we are going to use that particular moment as a port of entry for understanding, for gaining a better understanding of the internal experience of the parents. Another pillar is to be able to speak the unspeakable. And in order to do this, what we do a lot is to use the language that the parents are using when they are describing the trauma that they have gone through. And then also find connections between experiences. Follow the person's free associative flow of thoughts and feelings that can help clinicians to get a better understanding, of unconscious motives, fears, and wishes. And the most important thing is that, for example, if a pregnant person is talking to us about let's say, intense feelings of anxiety or feelings of depression that are not allowing them to be able to function in an appropriate way. You know, one of the things that we can do is to ask the parent, tell me when was the first time that you noticed that you were experiencing these feelings of a lot of anxiety. And sometimes they are going to retrieve a memory that they had when they were very young, when they were children, about the way let's say the father was physically abusive toward the mother, and the child at that time thought that the father was going to also to hit him or to be very violent towards him. So we are going to connect the present reaction that the parent is having with what happened in the past, okay? And what is important is not only to retrieve the traumatic memory, but to retrieve, and this is what we are going to be doing, supporting the parent to retrieve the affect of that memory. Because sometimes they talk about these traumatic experiences, but in a very, in a way in which they are not expressing any affect. And if they don't integrate the affect of the memory with the memory, they are going to tend to repeat this with the next generation. That's why this is important. And also for us to be able to remember that the suffering, there is a lot that there is a lot of suffer under the rage, or the when the parents are very angry. You know, we really need to be attuned with that anger, because, or with that rage, because we really need to know that what is underneath the anger or rage is a lot of suffering, a lot of pain, okay? Another thing is to try to understand that sometimes there are going to be some disagreement between the parents or the parent and the child, but this is going to, the way we mental health providers need to understand this is that what happened is that in that particular moment, there is going to be a conflict between important values that each one of them has, but they are crashing to each other. For example, during the postnatal period, the mother is not sleeping, she's exhausted, she's very concerned about becoming a good mother, and probably her sense of agency is not the ideal. And what happened is that she has a baby who needs to be fed every, let's say, the newborn every 3 hours, more or less. And so the needs that the mother has about resting are going to crash, are going to be in conflict with the needs of the baby. And we really need to help this mom to be able to see that she is trying her best to meet the needs of the baby, and for us to be able to see the benevolent piece of this interaction between the baby and the mother, okay? And we also need to offer kindness. And what does this mean? Is because we truly believe that if we offer that, that is the beginning of the healing process, and we are going to try to eliminate the idea of shame or guilt in the parents who are having a very difficult time. Because remember that sometimes the trauma response has to do with guilt and with shame. And another thing that is very important is to be able to encourage hope, trusting that things can be better, and that because if the parent is going to start thinking that, although right now I am feeling very bad, but I am in this relationship with my therapist, and she is assuring me that things will be better, that I am going to feel completely different when things start to work out, things like that. that is going to be very important, and that is going to motivate the client to continue working toward the healing process. So now we are going to be talking about the stages of pregnancy, and the stages of pregnancy, the way we conceive them are the first trimester, the second and third trimester, and the postnatal period, okay? Here, what is important that I would like to be able to share with you is that we have here the 3 trimesters, and I want to talk a little bit about what type of interventions we provide. And what we have been learning doing this work is that during the first trimester, the parent is going to have this idea of the imaginary baby, the baby that he or she is imagining to have, okay? On the other trimester, the second one, the parents begin to have a picture of what we call the symbolic baby. What does this baby represent for the parents, And we are going to be exploring several things during the second trimester. The maternal and paternal attributions, that they can be positive or negative, as you were saying, and also how the maternal or paternal identity is going to be developing during this trimester. In the first trimester, what is important to explore is if this pregnancy was planned, if it was a wish, and if the parents made the decision and how they made the decision to continue with this pregnancy. Those are the kind of things that we really need to explore. As also, for example, have you thought a little bit about what you would like to have, a baby boy or a baby girl? Things like that are the things that we are going to explore in the first trimester. Then in the third trimester, we are going to prepare the family to be able to welcome the baby, but now they are going to welcome the real baby, not the baby that they imagined they were going to have, or not the baby that represents something for this particular family, okay? I am going to share with you this vignette because I think that that is very important. Elena is a 28-year-old immigrant woman from Guatemala who was referred by OBGYN for perinatal CPP. This is her first child, and she is 26 weeks pregnant. This was not a planned pregnancy, but wants to continue with it. And the OBGYN physician was concerned because Elena is not following the suggestions to cope better with her high blood pressure, the level of depression that she was experiencing, and gestational diabetes. So these are some of the symptoms that Elena was having at the time of the referral, or the medical problems that she was having. Another concern that the OBGYN physician had is that Elena was not bonding with the baby because Elena was not talking about pregnancy. She was ignoring the different medical situations. She was not following up with the suggestions, okay? So now, one of the things that I would like us to do is, as a group, because this is not a very big group, instead of going to small groups, I would like us to think about these particular questions. How would you frame perinatal CPP to Elena when you meet for the first time with Elena? What are your main concerns about her situation and why you are concerned about that? And how was for you to hear this vignette? You know, how Elena is experiencing her pregnancy at this particular moment. So think about how would you frame the PCP CPP to Elena, what are your concerns and why you have those concerns, okay? And now, let's start with the first one. How you are going to frame CPP to her, and then we will talk about the main concerns and why, and your experience of learning about Elena, okay? Okay, good. So let's start, and I would like from group number 1, who would like to report to the big group? What were the things that you discussed in terms of how would you frame the perinatal CPP? What were your main concerns and why you had those concerns? And what was your experience listening to the story of this woman? So from group 1, who would like to represent the group?
I can share.
Okay.
So
Yeah.
in our group, we were talking a bit about how we would present PCPP to Elena, and framing it as pregnancy being a very stressful time, especially since it's her first child. And that it might be nice to have someone to talk to about her concerns, and also to talk to about her experience with the OB and with the medical staff, and if she's had any difficult or stressful experiences working with them, or like trouble understanding why they're giving her the recommendations that they are giving her. Yeah, so that was for the first question.
Okay. And how was for you to hear the Elena's story?
It felt similar to other stories I've heard, and yeah, it didn't seem too surprising that she was having some depression, and especially with the pregnancy being unplanned.
Yeah, very good. And what about the group number 2? Who would like to share?
I think we might need a reminder of what group numbers we were part of, because I don't know if that was shared with us.
Yeah, actually, I think group breakout room 2 got disseminated into a couple other breakout rooms. So we got room 3 is our Maria, Karen, Reshma, and Shalanta.
So who would like to talk a little bit about your conversation in the small group?
I guess I can be the spokesperson,
Okay.
Maria and Shalanda and Reshma, you can chime in if I don't represent us well. Let's see. Speaking for myself, I struggled a little bit with how to pitch PCPP to Elena, because recognizing that she may not really be thinking about the baby, and all the ways in which I would think that you would be able to draw someone in. She sounds like she is more disconnected. But I thought that framing it as a service that can ensure that this very important but challenging time of pregnancy can go as smoothly as possible, and ensure that the birth of the baby goes as smoothly as possible. But then as we sort of talked about and thought about her situation more, I also realized that, sort of helping her to understand that it can be support for getting her very concrete needs met. We don't know anything about her sort of baseline life before becoming pregnant, but does she have stable housing? Is she food insecure? All those things that the PCPP could help with might speak to her a little bit more than sort of the imaginings about the baby when she's not yet connected to thinking about her own pregnancy. And then we sat with a lot of questions about her and her situation, like her immigration experience, her stress level, and how both the pregnancy and the stress may be exacerbating each other, that the pregnancy makes the stress level higher and the stress makes the pregnancy symptoms worse. So I guess we sat with a lot of wonderings and empathy for her about how difficult her situation might be, and really wanting to figure out a way to step in to help her.
Karen, I think that you are bringing up something that is very important for us to address, and is based on the information that you got from the vignette. You were talking about some of the difficulties about framing perinatal CPP to a mother who is not connecting with the baby. And this is a dyadic modality of treatment in which the baby is going to be an active participant of the treatment even before the baby is born. But I think that you mentioned things that you were able to identify. That is, for example, a lot of what is happening with her in this particular moment. And when we meet for the first time with a woman who was referred to us to do the work, one of the things that has helped me a lot, specifically with this type of cases in which the mother is not connected to the baby, and I don't know how to enter and bring up the baby, one of the things that I do is to ask the mom if she could tell me a little bit about what is her understanding about the referral that her OB made for her to my program. And sometimes with these particular cases, they are going to talk about, I think that is because I cannot control my blood pressure. It's very difficult for me to follow the instructions about when I need to get insulin or the type of food that I can eat and the food that I should not be eating and how often I should be. So what I try to do is that for her, that was her understanding. She's not mentioning anything about the baby. So that I see that as a port of entry in which I am going to tell the mom, yeah, and it seems that it has been very difficult for you, this particular situation of the medical situations that you are dealing with right now, that you are pregnant. So I think that together we will be able to think about in which ways, when you come and meet with me, you will be able to get the support that you are needing, because I am wondering that you just mentioned the food and the insulin and all of that, and I will tell her, because here we will be able to talk about this and to think about how we will be able to work in order to address that. And all of this is going to be very important right now that you are pregnant, because what you really want to do is to welcome your baby, that your baby is going to be growing and developing in the right way. So if we take care of these things that are happening to you, then later on, we will be able to think about, how you can welcome your baby. So I bring from the very beginning the idea that we are going to be working together. This particular woman, and if the other parent is in the room, I include the other parent, but always bring the baby, and that everything that she's doing right now during pregnancy, the message that I am sending her is that everything that she is doing during pregnancy, like taking care of herself, is going to be very important for the development and the growth of her baby. That is something in a way in which I can meet her where she is, because she's not talking at all about the baby.
Mm-hmm.
Okay.
Yeah, I like that you're starting where she is, but you're also helping her to begin to open up space for it. There's a baby coming. Let's welcome the baby.
So that's good. Thank you, Karen. And what about other people who would like to share what you talk about in your group? Or other thoughts that came up for you when you started to discuss this particular vignette, or questions that you have?
Yeah, I just want to say that we had a really good discussion. I was with Shireen and oh gosh, I'm sorry, where's the other young lady that was with us? Actually, we had a couple of young ladies, and we had a pretty good discussion, and we mentioned that we felt that it was going to be vital to assess the resources and access of resources that she had, being that she was a new immigrant, what family members were there, who her support system was, things of that nature. And then also, Shireen, this is her line of work, so she was able to frame it so well, as far as helping the client to have a buy-in in, accepting this psychotherapy versus being against it. And that was really good. And then she also mentioned noting the disconnect between the fact that even though it was an unplanned pregnancy, it was still wanted, but also her inaction of care towards some of her physical conditions. So the fact that it's a wanted pregnancy, but she's really not doing the things that she needs to do to take care of herself, might be a mental block that she doesn't realize is associated with the inaction.
Mm-hmm. And what you are talking about, Sonny, is, and this is something that I hope that it could be clear for all of us, is that during pregnancy and the postnatal period, we are going to see a lot of ambivalence, okay? Even in the best case scenario. With this particular woman, you were able to identify, and that was wonderful, that the woman was not taking care of herself. On one hand, you brought up the idea that the woman was not expecting this baby, did not plan for this baby, but she made the decision to continue with the pregnancy. Okay, but at the same time, she's not taking care of herself and she's not taking care of the baby. So this is a very sad but beautiful example about how ambivalence is going to be displayed during pregnancy. Okay, and how we need to address for example, with this woman, because I want to base everything on her strengths, on her internal resources. And one of the things that I would tell the woman is, it has been very difficult for you to take care of yourself in terms of your diabetes and your blood pressure. But one of the things that you are doing in an amazing way is that you made the decision to come and meet with me. And together we will be able to work throughout all these things. So we need to address the ambivalence, but to engage the woman in the things that she is doing in a good way. Because what we want to avoid is to reenact the experience that she has had with the medical providers. That she goes, she's trying very hard to go to her medical appointments, and the doctors are telling her, oh, your diabetes is very bad, your blood pressure is awful. We want to avoid that. So what you brought up was very, very, very good. Other people who have other ideas or thoughts or comments?
Well, one of the things that we also talked about in the group, and Sony brought a lot of this in too, was thinking about the cultural pieces. And for this mother, you know, the message we're getting in the referral is that she's not taking care of her health. And, you know, we want to also bring in the baby, right? The impact on the baby potentially. But we want to also understand her perspective. And from her perspective and the knowledge she has, or the resources she has, or dealing with the limitations she has also as a new immigrant or resource needs, bringing in how she might be, what is her opinion of it? Like from her perspective, she may already be doing certain things that she thinks are helping her in terms of her health, but this provider is not seeing it in that way. So we also want to understand her perspective. Does she acknowledge that she has these health conditions? And from her perspective, how is she treating or addressing those conditions? She might be using a different type of treatment based on her own cultural background that she believes is addressing that those health conditions. And that may be differing from how the provider is instructing her to address the conditions. So I think that's also important to bring in.
And again, sharing something that you are saying that I really like is that how we, in order for us to strengthen the therapeutic relationship, we need to see this woman within the cultural context, and at the same time, not to focus only on the challenges that she's experiencing, probably because she's a new immigrant. And as you were saying, she's, from her perspective, she's taking care but probably in a different way. But I would like to add something. One of her strengths is that she's attending the prenatal care. Probably she's not following with what the doctors are saying, but it's important for us to highlight that in front of her, because she's doing something about taking care of herself. She's coming to the prenatal care, and she came to see me. So that is something that is telling me a lot about the internal resources that this woman has. Okay, so that is very good, very good. So tell me, other people, what do you think about this particular vignette? Do you have some concerns about this particular situation that she's going through? Let me frame the question in a different way. What could happen if, instead of meeting her where she is and trying to engage her in this therapeutic alliance, what could happen if I fall into the same pattern of interaction that she has had with the providers at the hospital? And that I am going, if I tell her, you know, it's going to be very important for you to come and see me, because if you do not take care of your diabetes and your blood pressure, what is going to happen is that this is going to have a huge impact on your health, the way you are going to deliver your baby. Probably you will have seizures during labor and delivery, and that is going to put at risk your baby. If I say that to her, that is real, that is something that probably is going to happen if she doesn't take care of herself. But if I say that, what would be the risk and my concern?
And it's not coming back entirely.
Exactly. She's not going to come back. What were you going to say, Alejandra?
Yeah, just the risk of her shutting down, the risk of her feeling maybe kind of like I wanted to say, like the repeating cycle, like, okay, I'm feeling ashamed, I'm feeling embarrassed, like I'm a bad mother because I would be putting my baby at risk. So yeah, just really shutting down, and like, you know, you don't people don't want to feel ashamed and guilt when they're already carrying a lot of that.
Yeah.
So the repetition of the cycle, like we were saying, we don't want to re-traumatize the client and have them have a similar experience to what they've already been having perhaps, and feeling judged.
And Alejandra, I want to highlight what you said, because what you were saying is you were talking about the guilt and the shame, and those are trauma responses. Okay, and you were able to identify that. And at least we know how it has been the pattern of interaction with the OB. Okay, but probably what happened is that even before that interaction, she has had in her life other experiences of relating to other people in a similar way. And that is what we call the internal working model that she learned from early experiences. And what I want to do in my therapeutic alliance with her is to give her ample opportunities to be able to experience that there is another way to relate to other people. Okay, so for me, I think that that is something that is very, very important. And I would like to ask to the whole group, how many of you have been working with pregnant women or with women with newborns? Joanna, Shireen, Rhiannon, Sonny? Okay, so you have a lot of experience. That's what I am getting. Alejandra, have you been working with pregnant women?
I work with 0 to 5, so
Okay.
yes. And I was just telling the rest of the group, I recently went to the CPP training, and so I'm building my caseload, and this is so helpful to be able to talk about it out loud, because these are real conversations I'm going to be having. So not necessarily pregnant, but very young children.
Oh, I'm so happy that you were able to be trained in CPP. And I just want to let you know that we have also a training in Perinatal Child-Parent Psychotherapy, a learning collaborative. But I think that what First 5 is doing, that I think that is amazing, is to be able to convey this information to other people in the mental health field, even if you don't go through the formal training in perinatal CPP, because the idea is that with this information, when you are working with families who have children from 0 to 5, you can use this information, even if you are not working with a mom during pregnancy. But if you are working with some parents and a very young child, this child at some point was a newborn.
Yes.
And so, and the mother was pregnant, the parent was pregnant with this particular child. So it's important to have this information.
Yes, it's very relevant, very relevant. A lot of parallels.
Good.
But yeah, thank you.
You're welcome. Thank you. And so before we move on, I would like to ask you, do you think that this particular vignette was helpful for you to start conceptualizing the work of perinatal CPP?
Yes, very helpful.
Okay, good. Because that is the idea. The reason why we are providing clinical vignettes is because of that. Okay, so let's move on. And I am going to share my screen. So we were able to talk a lot about Elena. Now I am going to give you an overview of the perinatal mental health psychotherapy. We have an initial phase that also is called foundational phase. Then we have another phase that is the development of the treatment plan of care, that we do that with the parents. And then we have the termination or the last phase of the treatment, that is when we invite them to reflect about how it was for them to be with in this type of treatment. So during the initial phase or the foundational phase, what we are going to be doing is that we are going to be framing the dyadic or triadic work. We are going to invite the pregnant person to think about if she could like another significant other, that it could be the father, another mother, whoever is going to be involved with this baby, if they would like that person to be part of the treatment, okay? In this phase, we are going to try to strengthen the working alliance with the client and to create a safe container in which they will be able to feel that this is a good space for them to talk about several things that are related to their pregnancy and their postnatal period, okay? And we are going to be gathering personal information of the client as well as the family information that they are going to provide us. And we are going to share the results of this initial phase with the parents. And when I am talking about gathering family information, I am talking about asking questions in relationship to how was for them when they were children, and we use different instruments to gather information about traumatic or difficult experiences that they had when they were very young children until the age in which they are right now. And then also we are going to gather information about how we can describe the patterns of interactions that this particular pregnant person is having with other people. That means what we call the internal working models. And I am going to explain later how that works, okay? And of course, we, in the next session, this is going to take a couple of sessions to do all of this. But the last session that we do during the foundational phase is that we are going to meet with the parents and we are going to share the results that we got from the treatment, okay? Then we are going together with the parents, we are going to develop a treatment plan of care. And I am going to be, how we do this. What I am going to be doing is that I am going to address the trauma history that they shared with me. And that is, I hope that all of you had the opportunity to read 2 articles because they are very good. Ghosts in the Nursery and Angels in the Nursery. In the nursery. When we are talking about the ghosts, we are talking about those experiences that happened when they were very little, based on the way they were, their parents related to them, okay? Because sometimes their parents related to them based on traumatic experiences they had. And also, but it's not only to focus on the ghosts, we need to focus also in benevolent memories that these families are having. And those are called the angels in the nursery. Those times, even for families, for parents who have gone through a lot of abuse from their parents, sometimes if we ask them, if they can talk a little bit about moments in their life in which they were feeling safe, cared, and loved by someone else, probably not their parents, but probably they are going to talk about, oh, I remember that when I was witnessing a lot of domestic violence at my house, I remember that at some point my grandmother would come and invited me to her home. And I remember that she was baking these beautiful cookies that I can even smell the cinnamon of the cookies. I can see the kitchen of my grandmother. It's not about the grandmother. It's about everything that was happening in that particular moment in which this woman or this father started to construct an image of how is to feel loved and cared and protected by someone. Okay. During the treatment, when we develop the treatment plan of care, we are going to be saying that we will be exploring the maternal and paternal, here there is a mistake, is maternal and paternal attributions. And we are going to be also exploring how the paternal identity development is happening during the different developmental stages of the perinatal period. Okay, and we are going to identify defenses in the parents as well as in the children. And what are the core interventions that we use in perinatal child-parent psychotherapy? As I was mentioning today at the beginning, this is a modality of treatment in which the approach is going to be a trauma-informed, a trauma-based. We are going to help the parents to seek the meaning of what they have been living. And the unborn baby is going to be conceived as a transference object from past experiences. And that's when we are going to be exploring the positive and the negative maternal and paternal attributions. And also we are going to be able to see how the parents are developing the identity, how they are going to make the transition from being pregnant to become a parent, okay? Because something that is important is that during the perinatal period, when the parent is pregnant, one of the things that happen is that they are not going to be anymore the daughter or the son of this particular person, or the sibling of their brother or sister, but they are also developing a particular identity as a parent for this particular baby. And that piece is very, very important. Okay, we use a lot of non-didactic developmental guidance, but always within the cultural context. We are not teaching them parenting skills, or we are not teaching the parents, your baby is in this developmental stage, so you can expect this, this, and that. And the reason why we don't do that is because what we want is specifically for parents who have significant history of trauma. What we really want is to give them ample opportunities to develop a sense of agency as a parent, not to be feeling guilty or ashamed because they are not doing the right things, and we are the ones who have the knowledge, and I am the teacher, and I am going to teach you how to become a good parent. We don't do that. We really, for example, we are going to be talking about a particular developmental stage of the baby, not addressing that to the mom, but talking to the kid. For example, when I was working with a toddler, I remember that at some point the mother of this toddler was very depressed, and the toddler had a little tricycle in the living room when I was doing a home visit. And I remember that the mother told the kid, "Do not ride your tricycle because you are going to fall down." And the kid, a 2-year-old, what he wanted to do is to see how he can master the tricycle, and he decided to ride the tricycle. and he was doing a very good job, but at some point, he fell down and the tricycle fell on top of him. And the first thing that the kid did was to turn around and look at the mom to see how the mom was going to respond. But the mother, what I noticed is that the mother was not moving she was not acting in the way in which we hope she could do, like go and grab the kid and take off the tricycle and comfort the kid, that by this time the kid was sobbing and crying and feeling very bad. The mother was not doing that. But I do not want to put her in the spot by telling her, you should stand up and go and do this with your kid. Instead of providing an intervention directed to the mom, what I made, the decision that I made was to do an intervention talking to the kid. And I said, oh, little Johnny, you were really trying to see if you can control the tricycle, and you ride the tricycle and you were doing very well. But at some point you lost the balance and then you fell down and the tricycle was on top of you. Wow, little Johnny, I think that we will need to wait a couple of more months for you to be able to take the tricycle and have a different type of balance. I was providing non-didactic developmental guidance. That means kids at this developmental stage cannot do this, and you should be helping her. Instead of saying that, I am talking in a way that is non-didactic to the child. Okay. We also provide concrete assistance. That means, for example, if the mother and the father are having their baby, they deliver the baby, and at some point they are going to be discharged from the hospital. They are not going to give them, the baby is not going to be discharged unless the parent brings the car seat. And sometimes they don't have the money to buy the car seat. And as one of the families told me at some point, but why do I need a car seat? Because we don't have a car, Gloria. Okay, so what I did was to connect the parents with the Family Resource Center, who was, they were able to provide the family with a car seat. That is usually what we talk about, providing concrete assistance, okay? And also, another thing that we do before they are going to be, or even before they deliver the baby, we start talking, exploring with the parents where you would like your baby to get the pediatric care. And we are going to coordinate that appointment with the pediatrician, okay? So the family is going to experience this continuity of care. Another important thing during the core phase is that we are going to prepare the family for labor and delivery. And this morning we were talking a little bit about how we can prepare them for labor and delivery, how we can anticipate what is going to happen. And they are going to construct something that we call a birth plan, in which they are going to be putting, if they want the epidural, who would like to, the mother who would like her to have in the room while she is in labor, and to plan all of that so she can anticipate what is going to happen. If they have other children, who is going to take care of the other children, okay? And then something that I try to do is that I ask the parents before the day in which they are going to deliver the baby, I ask the parents, what are the words that they would like to tell their baby? At this point, they know the name of the baby. I use the name of the baby to humanize this baby. So if they are going to have a little girl and the little girl is going to be Mary, I am going to ask the parents, can you think a little bit about what you would like to tell Mary when you are going to meet her for the first time and you will be holding Mary? what are the words that you would like to tell her? How they are thinking about welcoming Mary into the world, okay? And we also are going to be helping the parents to think about the internal experience that the baby is having. So that is what we call enhancing the reflective paternal or maternal, enhancing the maternal or paternal reflective functioning. And then we are going to be working very hard during the different developmental stages of the perinatal period, in the way in which we want the parents to start developing a very strong bond with their baby during pregnancy, because this is going to provide later on a secure attachment. Okay. So let's stop here. And I would like to go back to all of you. And I would like to ask you a little bit about how was for you to hear this information? What are the thoughts or questions that you have about the information that I just provided you with? Do you think that these are some issues that you will be able to use with the clients that you serve?
I appreciated your example of the non-didactic developmental guidance, and you created a vivid picture for me of sort of recreating scenarios that I've experienced many, many times over my career, where a situation arises and you feel so strongly pulled to directly intervene in some way because there's something happening that sort of violates your value around how children should be treated. But really the importance of taking some deep breaths and trying to figure out how you can intervene to support the relationship between that parent and the child, and not insert yourself as the better parent or the expert, because that only works for that moment. And you go away, and the dyad are left to repeat those patterns unless you help them figure out a way to shift it.
And sorry, Karen.
So just appreciating, the opportunity to think about that, and the importance of each of us who are working in these scenarios to tend to our own regulation, sort of notice what's happening for us, and resist that pull to be that better parent.
Thank you, Karen, because I think that what is important during the perinatal period is to think about these moms or dads who have gone through significant history of trauma, specifically in terms of how they were treated as young children. And what earlier we were talking about that some of these parents are having a lot of guilt, experiencing a lot of guilt and a lot of shame. So what we really need to keep in our mind is how we are going to provide them with ample opportunities of feeling good about themselves as parents. And if I teach one of these parents to connect better with the baby, or to do things that are going to be very important for the baby or the child, the message that I am telling them is, you are not doing enough. You are not a good enough parent. And we need to avoid that. We need to go to the other extreme of the pendulum, how we can help them to be able to develop a sense of agency as a parent. So that's why I really talk a lot about non-didactic developmental guidance. a lot of people, sometimes they ask me, for example, the people that I supervise in my program, they ask me, Gloria, do you have information or books that I can, read about parenting? And I always say, no, I think that it's important to think a little bit about why do you want those type of resources? Because I want to teach the parent to do something completely different. And I always say, if we keep in our mind that the theoretical approach is psychodynamic, the need to change needs to come from within us, not because other people are telling me to do this. You know, there is a beautiful book that was written by, that it's called From Parenting from the Inside Out. And it's a beautiful book because it was written, I think that by Stern and Daniel Stern, I think, and the preschool teacher, a preschool teacher that he met when her kids were in school, in the preschool. And I really love that book because they are talking about this, you know, they are talking about this particular situation, how important it is for us to be able to understand that the parents are relating to their babies in one way or another based on the goals of the nursery. Okay, so thank you for saying that. What other comments do you have before we move on? How was for you to hear this information? And
I think it's helpful when you're providing these examples of the work that you're doing, and just it's one thing to hear about how to do non-didactic work, and then it's another when you have an example that you're relaying to us and we can kind of picture it in our mind. Then I was thinking about CPP in dyadic therapy, how we're holding both individuals that are part of the dyad in the room, right? And there are times when we have to think about who are we going to emphasize in this moment? Are we going to emphasize mom's perspective? Are we going to hold the child in this perspective? And in thinking about the perinatal work, it's a little bit less intuitive because the baby's not there yet in the room, and yet the baby is there. And so you're holding mom and you're also holding this baby that is not yet born. Mm-hmm. And how challenging that can be when and how important that can also be that you're having to uplift this baby that is not even physically present yet in the outer world, and yet you're holding their perspective. But how important is it to hold this parent? How critical is that?
Mm-hmm. And I am going to share with you one of the interventions sometimes I use during the perinatal period, during pregnancy, when the baby is not in the room, and how I give voice to the baby. I usually begin every single session asking the parent, tell me a little bit, how was for you? How it has been for you since the last time we met. I do not ask, and I work a lot in Spanish, and because this is a cultural bias, put it that way, for Latin American people, we don't talk about feelings, but we experience the feelings and we display feelings with our bodies, okay? So I never ask them, how do you feel today? But I ask them, tell me a little bit how it has been for you since the last time I met you. Because if I ask someone, how do you feel? The response that I am going to get is fine or bad. But if I ask them how it has been for you, the parent is going to elaborate about his or her experience, okay? And when I finish to do this interaction with the parent, asking the parent this question, I turn around and I look at the belly and I ask the baby, so little Johnny, your mom is telling me that last week it has been a very difficult week because you moved from one home to another one and there was a lot of stress. And but your mommy and your daddy are moving to whatever. But I do not talk about the baby. I do not ask, tell me how it has been for the baby. I ask the baby. I begin to humanize that baby. I have a relationship with the baby. And what it is amazing using this simple intervention is that a couple of weeks later, when the mother or the father come into my office, and then I ask them, tell me a little bit how it has been for you since the last time we met. You know how many times they responded to me? No, do not ask me. Ask little Johnny. He needs to talk to you about how it has been this week. And I said, oh, little Johnny, it seems that you need to tell me a lot about how it has been this week for you and your parents. And then one of the parents said in one occasion, the mother said in one occasion, is because I have not been able to sleep, Gloria, because as soon as I lay down, the baby begins to move, and he's not allowing me to rest. And then I am going to talk to the baby and say to, and this is what I say to the baby. Oh, little Johnny, your mom is telling me how every time that she's trying to rest and she lays down, then your position in her belly changes and you have more space to move. And because you are in the last part of the pregnancy, is in this couple of months, you are growing and developing in an amazing way. And so I am wondering how is for you when your mommy is active, you know, and she's moving and you don't have enough space. It makes a lot of sense that you are developing, growing, and every time that she is in that position, you begin to move more. I am addressing the baby and I am providing non-didactic developmental guidance because sometimes the mother might say, he is going to be exactly like my father, who he used to hit me and to kick me. And now my son is exactly like his grandfather. So the mother is giving intentionality to the behavior of the baby. So the mother is not looking at the real baby. She's still with this symbolic baby. My baby represents that men are hurting me. So this is a way in which I provide the interventions. Okay. What other thoughts do you have or questions that you would like us? Yes, Rhiannon.
Yeah, thanks. Gloria's presentation has been amazing. I'm curious if you've ever had a client who had a really strong identification with the aggressor and really had a strong conviction and belief in like corporal punishment, or that harming or hitting their kids was going to be the way that they knew that they were going to parent, and how, if so, how you dealt with that.
Yeah, and thank you for asking the question, because during the foundational phase, one of the things that we address, that we are exploring, is what are the thoughts that the parents have about raising their kids. If they are thinking that physical punishment is something that they are planning to use. So we assess that, because if we assess that from the very beginning, we will have the opportunity to be able to work with them before the baby is born. And one of the things that I remember is a mother who shared with me that when she was a very little kid, you know, her father and her mother they were not expressing, they were not displaying physical violence to each other, but to their children. They were very physically punitive toward their children. And both parents grew up like that, okay? And so when I met with the mom, she told me, of course, the way I am thinking about raising my kid is spanking him, because it's the only way in which they are going to learn things. And then I started in the foundational phase asking her, when she disclosed that her parents punished her using physical methods, I asked the mom, because then I was able to identify what is the ghost. The parents who were very punitive, okay? So I asked the mom, can you talk a little bit about how was for you when you were a 4-year-old, because she disclosed something that happened at age 4. And I said, can you talk to me a little bit? How was for you when your uncle taught you in a very inappropriate way, and you told your mom about what your uncle did, and your mom reacted in a way in which your mom and your father hit you with a belt instead of supporting you? And she said, they did not believe me. They punished me and they hit me with a belt. And I said to her, so the memory is there, and it's related to what she's thinking about in the here and now. I am going to raise my kids like this. And I said, so now you remember that situation. Let's try to think about how was that for you? Because at the beginning was like, oh, they did what they needed to do because blah, blah, blah. And I said, but you were only a 4-year-old. And your uncle was touching you, and he had been touching you for a lot of months. And how was that for you, that you did not have anybody who was protecting you? And then she insisted. I talked to my parents, but I thought that the way they responded was that it was not important that my uncle did this to me. And I said, and how was that for you? When you knew that something was going on with your uncle that you didn't like, and your parents hit you with a belt, how was that for you? And that was the first moment in which she was able to retrieve the pain, the affect, and to put together, yes, it was not okay. I was only a 4-year-old. And instead of helping me to understand what my uncle was doing with me, they sent me the message that it's okay to hit people, to kick people. So the boundaries that this woman had were completely blurred. If my parents can kick me and they can hit me with a belt, and my uncle can come to my body and he can do whatever he wants to do, the idea is I identify with the aggressor and I am going to repeat the same behavior. Because if I repeat the behavior, I have some sense of control. But that sense of control is not healthy. Okay, so do you see how I help her with the memory and help her to retrieve the affect? She was able to integrate, and by doing this little by little, she came before the baby was born. She and her partner, they came to the conclusion that they did not want to use a physical punishment with this baby. And that's the way we work.
Thank you.
You're welcome. So other thoughts, other questions that you have before we continue? And I noticed that Leah put in the chat the name of the book. I'm sorry, it was not Stern. It was Daniel Siegel and Mary Hartzell, the authors of the book, Parenting from the Inside Out, okay? But tell me, do you have other questions, other thoughts before we move on? Okay, so let's continue. So during the termination phase or the recapitulation of treatment, we are going to ask questions like, tell me a little bit about what did you learn about yourself? And what have you been learning about your baby? What are your concerns, your fears, your wishes about the future? Okay. I am asking these questions so they can reflect. And also what is very important is to ask the question, how are they experiencing termination within the context of traumatic experiences that they have had? If you are working with a client who has been abandoned, who nobody helped him as a child to be able to learn to say goodbye in a healthy way, the termination of treatment is going to evoke, is going to trigger a lot of very difficult memories. So we really need to anticipate to them, you know, from the very beginning, the treatment is going to be until your baby is going to be 1 year. And we keep reminding them, oh, your baby now is 3 months old, now is 6 months old. We have 6 more months to work together. Why? Because we want them not to be surprised by the termination phase, okay? Another thing that is important is to be able to help them to reflect about what is going to happen in the future when the baby begins to be more mobile and he goes off and tries to explore the environment, and he's going to be going to preschool and learning from other adults and other children. How is that developmental stage for the parents? What is what they will need to put together in order to support her child? So this, if you look at this, is also how we are you know, organizing the termination phase in the same way in which we have been doing the core phase, in which we invite them to really reflect on many things. Now I am going to have the opportunity to share with you a beautiful case that I like a lot. That is the case of Anna, Roberto, and Lily. And this is going to give you an overview of how we work in perinatal child-parent psychotherapy, okay? So, please, feel free to stop me if you have questions while I am explaining about this particular case, okay? So, with Anna, Roberto, and Lily, we are going to be able to see how the unconscious is working as a carrier of early trauma. That means the ghost in the nursery, and the baby is going to represent that. So the baby, the unborn baby, is going to be the one who is bringing the past into the present life of their parents. The clinical formulation is very important because it's when we are going to invite the parents to be in treatment. We are going to address obstacles in treatment. For example, when the family does not trust the therapist or does not trust the medical staff. Do you remember the case that we talked about this morning, in which the mother was attending the prenatal care, but the relationship with the OB was not the idea? We are going to be speaking the unspeakable. And the reason why we do this is because we are going to try to dispel harmful beliefs. One of them is, for example, my baby is exactly like my father. He's kicking me, and he's doing this on purpose when the baby is moving during the end of the second trimester, okay? And then how we are going to be thinking about making room to welcome the real baby. In this case, Lily. Okay, so I am going to introduce you to this beautiful family that I met a couple of years ago. And Anna is a 21-year-old woman who was referred by her midwife. She is 20 weeks pregnant. The medical staff is very concerned that she's not bonding with her baby. She does not talk about the pregnancy with anybody. She presented very sad, tearful, and unable to sleep, not enjoying activities that in the past she used to enjoy. Anna reports that she's not sleeping well and her appetite has decreased. So first of all, the concern about not bonding with the baby, we know about some of the symptoms, and the symptoms that we know about are what we call major depression disorder. So she's suffering from depression, and she's having some physical symptoms like she's not sleeping well and her appetite has been decreased. And with this woman, with Anita, what happened is that the doctors were very concerned because at the beginning, instead of gaining weight, the mother was losing weight. Now, let's talk about Anna's family history. And this is a beautiful case, a beautiful family, because both parents were part of the treatment throughout the perinatal period, okay? So when Anita was a 3-year-old, her father moved to the United States to work in the field. Anita's father visited his family in Michoacan, Mexico, only twice a year. Anna remembers feeling very confused when her father would say goodnight the following morning, and the following morning her father had disappeared. What happened is that during those times of the year that the father visited the whole family in Michoacan, you know, she remembers as a very young kid, a 3-year-old, that her father would put her in bed, kiss her, and say goodbye. But the following day, when she woke up, her father had disappeared. She didn't see him again for a long period of time, and nobody was available to explain to her what was happening. So she became very anxious about that. And her one of the things that had a huge impact is that her mother did not explain to her what was going on with the father. Another important piece of her history with her, in terms of her family history, is that her brother committed suicide in Michoacan when he was a 21-year-old young man. And Anna came to the United States when she was a 15-year-old, and in order to join his father. But what happened is that when she came, a little bit later, her father passed away, died in a car accident, okay? And she had another important thing in her life is that a year ago, before she met with me, she had an intrauterine fetal demise when the baby was about to be born at 40 weeks of gestation. And what happened with that is that one day she woke up and she started to stop feeling the movements of the baby. And she was at 40 weeks of gestation. So she got really concerned. She went to San Francisco General, and the doctors explored her, and they said, the baby's doing well, you are doing well. Probably in that particular moment, your baby was not moving because he was sleeping. Go home And if you don't start with the contractions tomorrow, then we will need to induce the labor. But you can go home and rest, go to sleep and try to rest and come back tomorrow. Okay, that is what happened in her family history. Now let's go to Ricardo's family history. His father left him behind in Mexico when he was a 5-year-old. And Ricardo's father died in California again in a car accident when he was, I think that he was 15, when he was 15 years old. And his brother had a long history of depression and he committed suicide. So I want you to start looking at the parallel between Anna's history and Ricardo's history. They lost their father and they lost their brothers and in a car accident and also in suicide in terms of the brothers, okay? And when Anna finally went to the hospital the following day and they were going to induce the labor, the doctors noticed that there was not a heartbeat in terms of the baby, and they let her know that the baby had died, okay? And the baby was a baby boy. They induced the labor. She delivered this baby who was already dead, and both of them were devastated, okay? What happened with Ricardo, and this is very important to keep in our mind, is that after he lost his baby boy, Ricardo started to have physical problems on his back and on his shoulders. And they developed in a way that he had to stop working, and he was in disability when I met him. And this is a very important piece because with Latin American people, the way they display their depression is through somatizing the symptoms. And this was a case that it was an extreme case of depression that the father was almost unable to function because of the pain on his back. So why is important to invite from the very beginning the father, if there is a father involved in these families? Because sometimes, unfortunately, the pregnant person often acts as the gatekeeper who exclude the partners from involvement with the baby starting in pregnancy. And that is very common, something that we see in very frequently. And so the PCP clinician considers the unborn baby and the newborn within the context of the family constellation. And here the clinical dilemma is how we are going to be able to identify if we can integrate the father in the treatment or if the father is going to be marginalized, okay? So timing of fathers or other partners' participation is often clinically determined. So we are going to ask the pregnant person, would you like your partner to be involved in the treatment? Why you don't think about that, and you can let me know in our next appointment. But we bring up the question about if the father or the other parent would like to be part of the treatment, okay? In this particular clinical case, the father was always an active participant from the very beginning of treatment. So I had the opportunity to learn a lot about how the fathers were, in general, how the fathers experienced the pregnancy of their partners, okay? Because they go through different stages as well as the mom. So we talk about this. So when we are talking the baby about the unborn baby as the one who is carrying the past into the life of the pregnant parents. What we do with the ghosts in the nursery is that we are trying to link the past with the present. And so here, one of the things that I told Anna was how difficult was for you to understand why your father disappeared when you were sleeping. You were only a little 3-year-old. So I am taking the past, okay? Because this is something that she shared with me. And then the mother, I am listening with a lot of empathy, everything that the mother is saying. And the mother responds to me. Oh, because this part is very important for you to know. After the baby was born, the mother was talking about that she couldn't sleep at all because she was making sure to see if the baby was breathing and to see if the baby was alive, because she had this fear that the baby was going to disappear or the baby was going to die. And I am using the words that she used, disappear and dying, okay? So that is telling us how, as a little girl, when the father disappeared, in a way, her experience was, my father died, and I don't know anything about him, and nobody explained to him. So the mother, when I said that, the mother responded, so Gloria, do you think that that is why I woke up so often while my baby was sleeping? To make sure that my baby was not going away, in a way that the baby was not going to disappear or the baby was not going to die. Because remember, she had a previous experience in which her baby, when she wanted to sleep and go to sleep, what happened is that the baby died, the first baby, okay? So the mother, I am bringing the past and I am inviting her to connect that past experience with what is happening in here. And she was able to respond in that way. So, how we address obstacles in treatment, mistrust of the therapists and the medical staff. So I said, the mother said to me at some point, it is so difficult, Gloria, to come to the hospital and meet with you because she started to miss sessions at the beginning. She was not attending on regular basis. And I asked her one of the times, Anna, tell me a little bit, what is the most difficult part to come to the hospital and meet with me? What is the most difficult part of that, of doing that? And immediately she responded, it reminds me when I was pregnant before, and I used to come to the hospital and then my baby died before he was born. So she's connecting what happened in the past with the difficulties of coming and work with me in the hospital, okay? So how do I respond to her? Is like this. I am wondering if not coming to the hospital for your prenatal care or to meet with me, it is a way to protect yourself from experiencing very difficult feelings that remind you when you lose your first baby. So we go from the past to the present, okay? Acknowledging the difficulties. But I am not telling her, if you don't come to meet me, you will not be able to deliver a healthy baby, or you are not taking care of yourself because you are not attending the prenatal care appointments. It's only to stay focused on what is happening and trying to understand the meaning of her behavior. It's not that she's not coming to see me because she doesn't want to see me. It's because in a way she's protecting herself of re-experiencing very painful feelings. And then the clinical formulation is made as a way to invite her to treatment. So make the connection between feeling lonely, unloved, confused, and abandoned by her father, and the anticipated pain of losing her baby. And one of the things that she says is, I am afraid that my baby will die while she is sleeping. And she's talking about the baby girl that she had, with this new pregnancy. And she's saying, I am not resting, I am waking up because I am afraid that my baby will die while she's sleeping. And I respond, it is now that you are beginning to understand how difficult it was for you when you woke up as a little girl and your father disappeared while you were sleeping, or when you went to sleep and the doctor informed you that your unborn baby died. So the core treatment is in a way deepening the foundational work. So we are going back and forth between the present, the immediate past, and the childhood loneliness, the fear and the rage, seeking the emotional meaning of specific memories and fears. And then this is a statement that is going to illustrate what I was saying. I always had the fear that if I allow my baby to sleep, she would disappear. I had the need to constantly check in on her to make sure she was alive. I was unable to sleep, and my baby was not getting enough sleep. At times, I want to run away and leave her behind. I was exhausted, and I am terrified I will do that to my baby. So she was feeling a lot of shame, a lot of guilt, only to think about abandoning her baby, okay? And see the way I responded to her. And you did not leave Lily because you wanted to protect Lily from the impulse that you had about leaving her. In that way, I am telling her that there is a part of her that she was protecting her baby. So how we work during the core treatment of in the treatment phase, we have two tasks, the prenatal visits and the postnatal visits. During the prenatal visits, what do I have to do is to address the loss of her first child before being born, to support her to mourn the loss of that baby, and to mourn the loss of the baby that she imagined she was going to have, and cope, how we can help her to cope with the real baby who had died before being born. Because in order for these parents to be able to welcome Lily, now the baby that they are pregnant with, they need to let go of the previous baby, because otherwise they need to go through the grief process to mourn that loss in order to be able to let her go, to be able to connect with the new baby, okay? And in the postnatal visits, I needed to be very careful about the triggers that Anna was going to have when the baby was sleeping. And she immediately was able to share with me that she had those triggers, okay? And how we needed to address the triggers and how we need to support to retrieve the affect of earlier memories. And I talked to you a little bit about how we did that. Speaking the unspeakable, that in a way is how we are going to dispel harmful beliefs. And here we have shame and self-blame that are universal responses to trauma. I am bad, I made it happen, I will cause harm. And we saw that in Anna. She was saying, in a way she was telling me, probably my father left because I was a bad kid, okay? My core is that I am a bad person. And also, I caused that harm that my father caused, or probably I caused the death of my first son. So identifying and dispelling pathogenic beliefs is a core strategy that is part of any successful treatment, regardless of the theoretical orientation that we are using. It's important to address those beliefs, okay? And the mother at some point told me this, you know, it is such a relief to know that I am afraid of hurting my baby because I really want to protect her. When she was able to accept, to internalize what I told her, you are protecting your baby, she was able to articulate that. And she said, that means that I really love her. I did not know I could feel that. So do you see how the mother, with the support that I was providing her, she was able to acknowledge that there were moments in which she wanted to abandon the baby, but she didn't do it because she was protecting her baby from her impulse. And also she was saying, I am able to acknowledge that I have feelings of love toward my baby, that I could feel that, because in the past, because these ideas that I am bad, I made it happen, and I will cause harm, then I am bad. I am a bad person for my baby. So what is does speaking the unspeakable mean during the perinatal period? So we have been talking a lot this morning. We talk a little bit about, you know, creating the space to address painful events that are consciously remembered and acknowledged as real, and to bring the affect of those memories. Helping the parent find safe ways to articulate what the parent and the infant experience and they are feeling, and exploring possible causal connections between the painful events and the presenting symptoms. I told you about, for example, that Roberto was feeling a very acute pain on his back. And during the postnatal period, we were suddenly one day he comes and he says, I am not feeling anymore the pain. So we work around that. What does that mean? And he was able to articulate what happened is that it was not only until now that I can say that what I was feeling on my shoulders is the big responsibility of supporting my mother and my 3 sisters when my father died. But he was able to articulate that. Also, being attuned to the infants and the parents' rhythm as the parent explore the links and create safe ways of relating to each other. So now we are making room for the real baby, for Lily. And what we are going to be doing is that the parents are going to be invited to create a narrative of labor and delivery, and for us to pay attention about how that narrative was constructed. If they thought that Lily was an active participant during labor and delivery, they are going to talk about how was for each one of them when they were able to hold Lily and how they welcomed Lily, okay? Another thing that we worked about when Lily was there was the part of co-physiological regulation, how the parents are going to help Lily regulate in feeding episodes, sleeping episodes, and also crying episodes, okay? Because the co-physiological regulation is going to be the foundation for the emotional and behavior regulation. And we explore a lot about how the family responded to the adjustment of having Lily as a as an active participant of the family constellation, you know, and also how we are going to integrate separate agendas to be able for us as clinicians to tolerate the ambivalence. For example, when we hear things like, I want to run away and leave my baby behind, you know, I feel guilty because I know she needs me. There is a lot of ambivalence. And that one of the things that we worked through was that I said, when you are exhausted and you really need to rest, I am wondering, what can you do, Roberto? And he said, well, if she if she pumps out the maternal milk, I will be able to feed Lily with a bottle. And that's exactly what they did. We explore during this phase, you know, the mother's perception of the baby and the father's perception of the baby, because that is going to give us an idea of how we can continue working with them. And then we are going to explore how the maternal role has been going on, as well as the paternal role, how they are identifying themselves as the mother and the father of Lily, and how they are coping with this new role as parents, okay? And how they are tolerating ambivalence and coping with identity development. Because right now, the focus is on, I am the father, I am Lily's father, I am Lily's mother. So the focus is on Lily and the role that they have as being the parent of Lily. And during the closing phase, you know, we are trying to recapitulate the treatment. And the mother was saying, you know, I can't believe that there was a time when I was not taking care of myself and my baby during pregnancy. She's reflecting on that. A mindful reflection. I still get tired and concerned about Lily, but I understand better where my fear is coming from, because she was able to integrate the past with the present and to anticipate the future. When she begins to walk, Anna said, when Lily begins to walk and separates from me, I will be there for her if she needs me. So for her, is telling me, I am not going to think that Lily, if I don't see her, I am not going to think that Lily has died or that Lily has disappeared. I need to be the secure base for my baby, so my baby Lily can go and explore the environment, but always with the understanding that if she needs me, I am here for her. And that was a beautiful way of terminating the treatment. Okay. What is important that I would like to share with you in this postnatal phase is that we need to do behavioral and emotional observations of the baby and the parent, okay? What do we need to observe? Identify the context in which we are making the observations. I really want to do my observations during a feeding episode, or when the mother is putting the baby to sleep, or when the mother or the father are trying to soothe the baby. Okay, and I am going to pay a lot of attention. I want to be attuned with the maternal mental states, how the mother responds to the needs that the baby is having. So right now, let me stop sharing, and I would like to go back to all of you, because we are going to have a couple of more minutes to talk a little bit about your thoughts, your ideas, your questions about this particular presentation. I would like to hear from you. What were the things that you think that were useful, the things that you think that you will never use, I want us to have this conversation together.
I think I found it all to be very useful, everything I would use. I really appreciate the case presentation, because I think it really brings the examples to light. The quotes, so you're getting a sense of dialogue and how to ask these questions, or how someone might respond, and how do you interpret that? I think, and maybe this is out of the scope of this training, because this is more of a introductory training, but I would love to learn more about some of the screening tools that you use when you're doing this work. And I'm sure that comes when you do the actual training for PCPP. So yeah, I appreciate the articles. And I know that there are also, I'm sure, screening tools that you're looking at or using, or maybe not. And so I'd love to hear more about your thoughts around sort of the assessment and bringing in the history. And
I think, Shireen, that you are bringing up something that is very important, because we are talking about the foundational phase, the initial assessment. And I do a training only on that. What are the domains that we assess during the perinatal period? Because there are some particular domains, and I can talk briefly about them. And one of the domains is about the perinatal history of the mom, how many times she has been pregnant, how many deliveries she has had, what type of delivery she had, vaginal, or if she had a C-section or a traumatic delivery. We go through a very detailed exploration of her perinatal history. We are going also, another domain is the traumatic history, since she was a very young kid until the age of that she has when you meet with her. That is one domain. Another domain is a pattern of interactions with other people. We use that. And also the family history. That is another domain. What other things? Another thing is what instruments we are going to use, Shireen, to address if the baby is developing and growing as it is expected. And we have several instruments that we are using for that. What other things that I would like? We also talk a lot about how to make behavioral observations during in ways in which we can get a sense of how the mother or the parent in general is co-physiologically regulating with the baby, because we truly believe that co-physiological regulation is the foundation of behavioral and emotional regulation for a baby. Okay, and so we have the instruments that we use in PCPP. But we also have another list, because that depends. What is important is to assess the different domains. The instruments that you use, we can give you a list of the ones that we use, but we have another list of suggested instruments that you can use. Okay? I don't know if that responds to your question. But yes, that is
really helpful. Thank you.
That is part of the perinatal CPP. But a couple of months ago, I was invited to one of the clinics here in Richmond, early childhood mental health clinic.
Yeah, that's my clinic. I'm the director of administration there. Yeah.
Oh my God! So I have been working with them for the last 2 years. And I have been providing some of these trainings. Nice to meet you.
You as well. Yeah.
Yeah, but we can do that, of course.
Dr. Castro, I had a couple of questions, just kind of regarding more training. So I know that there's the CPP model, and are you, it sounds like perhaps that there's also like a prenatal CPP. Is that correct? Is there like a training model for prenatal?
It's called Perinatal CPP Learning Collaborative. And yes, we are in the process that this is part of the dissemination team of CPP, but we are launching the first couple of trainings in perinatal CPP, and one of the programs is the one that is directed by Cherie. I am working with Paola Escobar, and they went through that. I did this training for them because they really wanted to be trained in perinatal CPP.
Wow, that's amazing. That's great. Thank you. And then the last question is, I know you're going to be doing this in Spanish, and I would like to attend because I will be providing CPP services in both languages.
Oh, great.
And so so many of the concepts are so important, and like Shireen said, it's so great to kind of like see the examples and the dialogues and how you responded and how you framed things. And the whole time I'm thinking, how would I say that in Spanish? How would I say that? So how do I get more information so that I can attend the same training but in Spanish? Because I think it's going to really help me with conceptualizing and the language, because I will also be providing this service in Spanish.
Great, Alejandra. I think that is Leah was able to put here how you can register, and I think that is going to be in 2 weeks, I think, on a Thursday.
November 16th.
Yeah, so I will be happy to see you there. And I want to take also the opportunity, Alejandra, because I think that we really need to acknowledge the effort that Leah has been doing in terms of making possible that the PowerPoint has been translated by them, by First Five, into Spanish. And I want to acknowledge that. And I am very grateful that they have been doing that. And Leah has been a very instrumental support for me in terms of reviewing the PowerPoint and make sure that everything is fine. So I want to thank you, Leah, for all your efforts of supporting me throughout this process.
Yes, so helpful. So helpful. Thank you, Dr. Castro.
Yes, you're welcome. So other thoughts that you have, questions, concerns that you have?
I mean, if no one has a question, I did want to ask if you could speak more about the co-physiological regulation. I think I'm understanding it, but can you kind of explain that a little bit more if there's time?
Yeah, sure, Alejandra, because that piece is very important, and I just named that in this one. When we provide the learning collaborative, that we train for 16 hours in perinatal CPP, okay? So this is only like an introduction, and I just named that, but I can explain to you a little bit about what do we mean about co-physiological regulation. Okay, one of the things that is very important is to know that how children learn to self-regulate. And we are talking about very young children, okay? The only way we can understand this is that children are going to learn to self-regulate in the relationship with the primary caregiver. And that relationship begins even before the baby is born. Okay, we have been talking about how the mental state of the mother is having a huge impact on the way the baby is developing and growing. Even the structure of his or her brain is going to be modified depending on if the mother has high levels of cortisol or low levels of other neurochemical substances that I don't want to go in detail about that. But the thing is that once the baby is born, the primary caregiver, let's focus on the mother or the father. The baby needs to sleep, needs to create a pattern of sleeping, and also a pattern of how many hours I am going to sleep, how many hours I am going to be awake, the quality of the sleep. There are different stages of this cycle of being sleeping and awake, and how the parent is going to respond to this is very important, okay? Because do you remember with the case that I presented that the baby was sleeping and the mother would go and see Lily and try to make sure that Lily was alive? The mother was putting her finger over here, was touching her to see if Lily was warm, you know, and Lily was waking up. And the whole pattern of sleep was completely interfered by the behavior of her mother. So what do I mean by co-physiological regulation? We needed to help Anita to be able, when Lily was awake, to be able to hold Lily and to caress Lily, talk to Lily in a way that can conduce her mom's behavior so the Lily begin to fall asleep, and to respect the time that Lily is sleeping, not to wake her up just to make sure that she's alive, or not to wake her up because now it's 3 hours and I haven't been able to feed Lily. I am going to wake her up to feed her. In that way, we are interrupting the co-physiological need that the baby has to establish these particular patterns of feeding, sleeping, and crying. How the mother is going to respond to that is going to be crucial. For example, I am going to share with you this. It's a clinical case. The mother was coming to me and she was saying, I can't take it anymore, Gloria, because my baby, every time that I am putting my baby to be able to breastfeed my baby, it's an awful experience. Because my baby at the beginning is crying a lot and is having a very hard time latching to my nipple. And that is very painful for me. So finally, when he latches and he's able to latch, he begins to suck the milk in a very avid way. And that is hurting me a lot. And so I am pushing my baby because it's very painful. And then I repeat the same thing, and eventually the baby is being fed, okay? Then I notice that my baby does not want my breast anymore. So I am going to put him in this position to be able to get rid of the air that the baby has been swallowing when the baby was drinking the milk, okay? And then after that, the mother is explaining, I put my baby on the other breast. And what I notice is that my baby is not drinking anymore. So I put my baby to sleep. And then half an hour later, the baby is waking up and he needs to be fed. So do you see, the pattern is not the idea. And the mother at this point is not able to read the cues of her baby. And so one day in the session, I had the opportunity to see that cycle of that cycle of interaction between mommy and baby. And what I did is that the mother was very tense, putting the baby on her breast at the beginning. And I said, let's have a deep breath right now. This is going to help you to be a little bit more relaxed when the baby is going to latch, okay? And we did that, and that helped her a lot. And then I said, and right now, what I would like us to do, when the baby is finishing with his breast, I am saying, oh my God, it's because the baby is doing something amazing. He's only a newborn, and he's learning to latch, to get to the nipple, to suck the milk, to swallow the milk, and at the same time, he needs to breathe. This is a lot of work for babies, and they end up falling asleep. So one of the things that we need to do is really, and then I switch and I talk to the baby and I said, you did a wonderful job. And your mommy was putting you, and you were drinking in an avid way. But of course you were tired. And I am wondering if you need a little bit of time to rest. And then I'm wondering what could happen if after a couple of minutes, your mommy offers you the other breast. I'm talking to the baby. And then the mother said, oh, do you think that right now is a good time? And then she puts the baby on the other breast, and the baby begins to drink, but not in the same way as the first time. Why? Because right now the baby is more, he's not so hungry. And so the way the baby is sucking and swallowing the milk, the quality is different. And again, I talked to the baby about that. And I said, and of course, you are a little bit hungry, but not as in the first part, when your mommy was offering you the first breast. Right now you are hungry, but not so hungry. And then at some point, the baby leaves the nipple, and then the mother forces her breast into the mouth of the baby, and the baby does this. And I said, oh, you are letting mommy know that now you are full. You are doing a great job. Both of you are doing a great job. And the mother says, oh, Gloria, so right now he is full? Yes, he's full. He's letting you know. That is co-physiological regulation. But sometimes they need a little bit of help. And if the mother is doing this, the baby is learning that I am experiencing something in my body that I don't quite understand. I'm feeling a void because I am hungry, but I start to cry, and the environment, my mom, is responding to my cry, and the experience in my body is met because I am drinking the milk, okay? And this is the foundation, Alejandra, of behavioral and emotional regulation, because I am, as a baby who is developing and growing, I don't know how to wait until my mom is ready to feed me. So I am crying to let her know. But I am learning over and over again that if I cry, my mother responds to my physiological need. So that, in a very short way, that is what that means. Okay?
Thank you so much. That is so helpful. Thank you.
Okay. Mm-hmm. So other questions that you have right now?
I just remembered that earlier in your presentation, you referenced that there may be parental defenses, but also that there may be defenses in the infant. And I was wondering if you could say a little bit more about what that looks like and how that shows up.
Can you repeat the last part? Because this sound was not good. Can you repeat the question, Karen?
Yeah, sorry. I just remembered that you had said something earlier in your presentation about defenses in the infant.
Mhm.
And if you could say more about what that looks like and how that shows up in the
Uh-huh.
work with the families.
For example, what I was telling you in terms of the co-physiological regulation, what we need to be able to do when we do our observations, Karen, is I am having this particular session with this mom and this baby, and I am noticing how the baby is using this, turning around his head to let her mother know I'm full. The baby is in a way protecting herself, is using this behavior as a way to protect himself or herself. Is too much milk. Or not only is too much milk, but the way the intrusiveness of the mother taking the breast and putting the breast in a very particular way in the mouth of the baby is very intrusive. Okay, now we have also to think about what is the defense of the mother in that interaction, because probably the mother is projecting onto the baby, Karen, a need that does not belong to the baby, but belongs to her past, when she did not have enough food. And right now, she is forcing the breast because her idea is my baby is very hungry and I don't want my baby to go through the same things that I went. So that behavior is a defense in terms of the mother. And the baby also, for example, another defense, if you have a kid who is, let's say, a 5-month-old, and I go to your home and you tell me, you are the mom, and you tell me, Gloria, can you hold my baby? And I am going to say, yes, of course, if you want me to hold the baby, I will hold your baby. But what happens if I go to your home and your baby is not a 5-month-old, but now your baby is an 18-month-old, and you tell me, Gloria, can you feed my baby or can you hold my baby because I need to attend my other kid? This particular kid is not going to be feeling comfortable with me because I am not a familiar face for him. Okay, so the kid, what is going to be doing? If I come back the following week and the mother, and she sees that the mother is beginning to go to another room, the kid is going to walk towards the mom and is going to cling onto the mom. He's protecting himself because he doesn't understand what is going on with this lady. So those are the kind of things that in the session, I try to highlight to the mom by saying, oh, Lily, I notice how important it is for you to be right now with mommy, especially when who I am not a familiar person to you, I'm coming to your home. I'm noticing how important it is for you to be with your mom. So I am working with the mom about the meaning of her child's behavior.
Thank you. That was helpful.
Oh, you're welcome. Well, I really want to thank you very much. You were a very interactive, it was a very active group, and I really appreciate that. And I hope that the content of the presentation is going to be useful in your work, okay? And I hope to see some of you in our next training. Thank you to all of you.
So we'd like to thank Dr. Castro for this lovely presentation. We really appreciate you. And thank everyone for joining us today. I'll be sharing out the links and the recordings and everything a little after this session. Look in your inbox today for your evaluation. And thank you so much. And I hope you all have a great day.
Thank you. Bye-bye.